Okay, now I see it. Okay, good afternoon. Thank you for joining us for the Connecticut Comprehensive Pain Center webinar, Non-Opioid Analgesic Options for Chronic Pain with Dr. Andrews and Dr. Chamberlin. As a reminder, this webinar is being recorded and will be available for distribution. Please add your name in the chat so we know who is online, and we'll open the line for questions after the presentation, or you can submit questions via the chat. At this time, we'll be muting all participants until the Q&A period, and I will pass the mic over.
Good afternoon, everyone. Dr. Andrews and I welcome you back for another webinar. This one, again, as Kelly mentioned, is going to focus on non-opioid analgesic options for chronic pain. We defined our learning objectives as these three items. To define the role of non-opioid medications for analgesia in patients with chronic pain. We'll go over some of the categories of non-opioid pain medication options, and then describe the management involved. So to get started, it's important to recognize and remember that it's more than just acetaminophen and opioids. It really involves, if you work your way around these color-coded block system, interventions such as nerve blocks, cognitive modalities for distractive techniques, coupled with physical modalities like RICE, so rest, ice, compression, and elevation. And it's really this multimodal approach that achieves the greatest analgesic outcomes. So first, we're going to review non-opioid medication options. If you break medication, or if you group medications into three categories, we can actually look at three different ways that medications affect pain. So drugs that modulate peripheral sensitization by the way of their effects on the sodium channels listed here. So things like carbamazepine, oxcarbazepine, the TCAs. And then we move into descending inhibitory pathways. And again, there's overlap between mechanisms of action of a lot of the drugs that are involved, but these focus on norepinephrine, serotonin effects. Thirdly, we look at central sensitization. So calcium channel blockers, NMDA receptor antagonists such as ketamine and dextromethorphan, but also methadone and memantine fall into these categories. And there's a fourth category not listed here, and that's the others category. So this is where items like capsaicin which works by depleting substance P, non-steroidal anti-inflammatories or NSAIDs, COX-2 inhibitors, levodopa, and these all work, these others work different than these three main groups. But the main groups that are listed here are kind of the target of kind of non-traditional adjunctive therapy. Another way to look at it might be to look at the ascending and descending pain pathways. So if you look at the purple boxes located to the left and the lower right, we can affect transmission and conduction with the medications that are listed here. So opioids, local anesthetics, NSAIDs, anticonvulsants. But we can also inhibit perception and blunt modulation by use of opioids and other options such as SNRIs and anticonvulsants here as well. So it's this combination of agents that really achieves analgesic optimization. If you look at the range of low back pain pharmacotherapy and the literature that supports it, there's actually no definitive pharmacotherapy that shows or proves beneficial outcomes in chronic low back pain. We have data that is not great, but there is data that demonstrates likely benefit, such as opioids, antidepressants, NSAIDs, and acetaminophen. We know that skeletal muscle relaxants, or SMRs, have trade-offs in their role in their use in low back pain. And then there's limited data, so we list it as unknown, for epidural steroid injections and local injections. So we'd be remiss if we didn't briefly discuss acetaminophen. As we all know, it inhibits central prostaglandin synthesis without affecting peripheral prostaglandin synthesis. It's really beneficial when it's used as add-on for analgesia. It's an IV. There is an IV product that has comparable efficacy and outcomes with the oral agent and the oral formulation, excuse me. But it is more expensive, so there's really no added benefit for its use over oral if oral can be taken. And we should remember that single doses typically provide about 4 hours of at least 50% analgesia in a little over a third of patients with postoperative pain. best demonstrated by the reduction in opioid consumption in the first 4 hours postoperatively, but there's no reduction in opioid-related adverse effects when they're used in conjunction. So really, it doesn't necessarily off-put opioid use. It's really an adjunctive add-on. Finally, remember with acetaminophen that the optimal analgesic dose is 650 milligrams, that it is not a PRN analgesic. It's optimized through scheduled around-the-clock dosing. And those are two very important factors to remember when utilizing acetaminophen. If we move into NSAIDs, we pulled this chart. It's a chart that I've favored for a long time, but it's from the Canadian Medical Group. But it's important to realize that there are some drugs that are listed here that are not necessarily available in the United States. But why I like it is because it breaks NSAIDs down into categories that are a little bit easier to understand and also demonstrate differences in effects. So certainly at the top, you have your normal, well-known salicylates, also known as aspirin. But then if we get into the non-sibylated salicylates, the ones that offer less adverse GI reactions, perhaps have less cross-allergenicity in NSAID allergic patients, that might be salicylate or choline magnesium. Then you move into indole acetic acid. So this is your indomethacin and your sulindac. These are potential options for consideration. There is even some data that suggests that sulindac might be the preferred NSAID in patients with reduced renal function. There's some data specifically to renal colic demonstrating that that might be the preferred NSAID in that group of patients. Then you move into phenylacetic acids, which is inclusive of diclofenac and also the combination of diclofenac and misoprostol. So a highly potent NSAID, but with some limitations and an increase in GI risk and effects. Then you move into propionic acid. So this is kind of where the normal NSAIDs that you think of, the ones available over the counter, the ibuprofen, ketoprofen, naproxen group, this is where they all fall. Then you can look into a drug like the naphthylalkylinones, the nabumetone, and finally your COX-2 specific inhibitors, which are similar in efficacy to NSAIDs, but have demonstrated less GI upset and ulceration. I think the other important thing to realize about NSAIDs, but this is actually across the board in analgesia, is that there is an Oxford table that does the comparative analgesic efficacy. And so that's what you're seeing on your screen here now. The best way to kind of look at this is it's the boxed, the black boxed column actually demonstrates the number needed to treat. So this is the number needed, the number of patients that needed to be treated to achieve at least 50% pain relief over a 4-to-6-hour period compared with placebo in randomized double-blind single-dose studies in patients with moderate to severe pain. So you'll see that the first 3 drugs are COX-2 inhibitors. They're actually all not available any longer. But then you get into ibuprofen at doses of 600 and 800, which is really the optimal dose. And actually, it should be pointed out that ibuprofen 600 has the same outcomes as ibuprofen 800. And 1.7 patients needed to be treated, and the number needed to treat for comparative efficacy. If you work your way down this list, you look at optimal doses and their comparative efficacy. And I think it's important to realize that as we work our way down this chart, as you can see from the number needed to treat increasing, we get to the bottom of the chart where codeine and tramadol on the last 2 rows. Codeine is a 16.7 number needed to treat. And we know that codeine is probably really just a constipator. It's a great antitussive, but it's a terrible analgesic. But you look at tramadol, a drug that has kind of moved in and taken a hold in part of the marketplace with the whole opioid shift. And that number needed to treat is 8.3. So that suggests that it's not as effective as a number of the other medications. Even if you go up in dose, it does not gain a ton of efficacy. Tramadol 100 milligrams single dose is almost a 5 for number needed to treat. Less effective, if you will, than acetaminophen or ibuprofen at even a lower dose. Moving into the anticonvulsants, the prototypical agents that are listed here, gabapentin, pregabalin, carbamazepine, valproic acid, topiramate, these all look and act by reducing neuronal irritability. They're all indicated for neuropathic pain, or variations of it. So the gabapentinoids for postherpetic neuralgia, diabetic peripheral neuropathy, and fibromyalgia, valproic acid and topiramate for migraine, and carbamazepine has long been the mainstay for trigeminal neuralgia. Just briefly about gabapentinoids, we know that they have some of their best literature for support in postoperative use. So there's data that suggests that you can achieve a decrease in chronic postoperative pain with even just a single dose of 600 to 1200 milligrams preoperatively of gabapentin, followed by a single 600 milligram dose postoperatively. And the comparative dosing for pregabalin is listed there as well. What we do know is that while you might achieve increases in analgesia and perhaps reductions in opioid use, you will also have additive sedation, which is a big limiting factor for gabapentinoids. The biggest thing to remember with gabapentin is to start low and go slow. The typical dose to the minimally effective dose is 1800 milligrams for gabapentin. It goes up a little bit from there depending upon the indication, but you should really strive to achieve that 1800 milligram total daily dose before you determine whether or not the patient is a responder or a non-responder. I think one of the caveats to gabapentin is while you go up in the dose, the bioavailability of the drug actually decreases. So increase in dose actually does not correlate to a substantial additive amount of drug present. And that's something to definitely keep in mind, because patients may not have as great a response as you might anticipate as you really push the dose. Pregabalin is similar, but you don't have to worry about that bioavailability curve that I just described for gabapentin. There is better absorption comparative to gabapentin with pregabalin and suspected decreased somnolence associated with pregabalin. However, pregabalin, as you might recall, is a Schedule V drug. And this is because of a preclinical trial that showed that when it's combined with alcohol, there's an increase in euphoric effects and thus increase in abuse potential. And that's why it's categorized as a Schedule V. We've described the overall risk so far of the gabapentinoids, and they're similar for pregabalin. The biggest things to take away from both of the gabapentinoids is that they shouldn't be stopped abruptly, and that they have an increased risk for somnolence. The next two tables actually take a look at the clinical trials that are associated with gabapentin or pregabalin. This first one looks at is a meta-analysis that combines data on the outcomes in diabetic neuropathy, low back pain, and other pain syndromes that are listed here. But what you'll notice that's boxed off in red to the right is that there were a number of these studies that showed little to no benefit in adding gabapentin to the treatment regimen. Similarly, for pregabalin, the data is also weak, with only 3 of the studies that actually demonstrated any additive benefit for pregabalin for its use as an analgesic in pain patients. Moving into SNRIs, there was a study by Ho and colleagues that was published in the British Journal of Anesthesia. It was prospective. They looked at 47 patients that were undergoing total knee arthroplasty. And for 48 hours, they looked at comparative efficacy versus placebo, which in the placebo group, it was actually a morphine group. And in the treatment group, it was duloxetine plus morphine. So those patients received duloxetine 60 milligrams a day, postoperative day 0 and day 1. And they identified that less morphine was consumed in the combination group, so that group that had duloxetine on board. And there was no difference in pain score or adverse effects. So essentially what they've said, less is more. You did not need the opioid to achieve any greater benefit. You got the similar pain effects as you did with the combo, as you did with single agent duloxetine. Ketamine is a beast in and of itself, and we're not going to dive that deeply into it. But it's important to understand that it is a treatment option and your patients could be asking about it. So it's typically thought of right now as an adjunct to opioid therapy or an option for analgesic therapy in patients that are opioid intolerant or contraindicated. The dosing is listed here. It's relatively low dose and slow infusion that can be done intraoperatively as well as postoperatively.
The next thing we're going to talk about are local anesthetics. So I think you probably remember a time when peripheral nerve blocks were used only for patients undergoing extremity surgery who could not have general anesthesia. And they've sort of become the mainstay of reducing the need for post-op analgesia. There are a bunch of different ways that local anesthetics have been used for chronic pain and acute pain syndrome. So just starting at the top is more of a surgical technique with infiltration anesthesia. So that can be used prior even to first cut, and then again in the wound itself and at time of wound closure. IV infusions are obviously used in the middle of surgery to keep patients comfortable during their procedure. And again, as mentioned below, you see the peripheral nerve blocks that are most often used for extremity surgery, usually knee down and then shoulder, elbow, and hand. We do use neuraxial blocks that are more centrally acting. So these are your spinals, your epidural injections that you see for patients with disc disease and low back pain. The evidence has gone up and down concerning epidural injections. However, I think what I would comment is when your patient is at the point of oral medication no longer working for them, or horrible side effects, it's at least an option to try. It provides the patient the opportunity to avoid surgery, and the outcomes of surgery, spinal surgery, are about 50-50 for patients who have improvement. This may change as we get better at identifying which patients are going to do well with surgery, but for right now, this is the last thing that we have to use before patients who are on the road to spinal surgery go down that final route.
Shifting to another kind of newer entity would be the idea of low-dose naltrexone in the management of pain. And so this is a relatively busy flowchart, but I think the important things to take away from it is that Th17 cells play an important role in inflammatory processes. And so it's been identified that the downregulation of Th17 cells in rheumatoid arthritis in particular was an opportunity to demonstrate the effects of naltrexone. Now, the dosing is very important because, as you'll see on your screen here, there's standard dosing across the top row of 50 to 100 milligrams, and this is where it's often employed at the alcohol and opioid abuse dosing, if you will. But then you have low-dose naltrexone, and this is really single entity doses of 1 to 5 milligrams. And what they have been able to do here is demonstrate that it can reduce glial inflammatory response by modulating these toll-like receptor signalings. And it also systemically upregulates endogenous opioid signaling. So the idea of low-dose naltrexone has been beneficial in syndromes such as fibromyalgia, multiple sclerosis, Crohn's disease, cancer, and complex regional pain syndrome. Very low dose naltrexone, so doses of 0.001 to 1 milligram, may have similar effects. So they are actually studying those in those same disease processes I just listed. But this has been identified as being beneficial to minimize untoward effects in methadone detox tapers in particular. And then there's also studies that are ongoing for ultra low dose that we're not going to talk about here. So a couple of studies that demonstrated the effects were published in 2018. So fibromyalgia in particular, 8 weeks of 4.5 milligrams of oral low-dose naltrexone demonstrated about a third or a 30% reduction in symptoms versus only 2% reduction in placebo. In a longer-term study up to 20 weeks, demonstrated that over half of the low-dose naltrexone group had responders on just 3 milligrams of oral low-dose naltrexone. Similar effects, but even greater response rate were seen in Crohn's disease with only 4 weeks of a 0.5 milligram of oral low-dose naltrexone. Shifting gears once again, skeletal muscle relaxants. So skeletal muscle relaxants are often employed, but often misunderstood and misused. They appear to decrease discomfort and accelerate recovery in acute situations, but their demonstration for benefit in chronic low back pain or chronic pain syndromes is limited at best. My general rules would be that there may be benefit with NSAIDs in conjunction with NSAIDs in acute situation. that they definitely have adverse effects that can be problematic and that get worse with longer use, that you should avoid carisoprodol, period, and that there's no good data or consensus on chronic use. I understand that this is a busy slide, but there's a lot of helpful information on here, and I know that the slides will be made available as a handout post this webinar. But it's important to recognize that there's really two distinct subclasses of skeletal muscle relaxants. So you have those that are antispasmodics, the baclofen and the tizanidine, and these should really be reserved for patients with spasticity issues, patients that have spinal cord injury, multiple sclerosis, ALS, and the like. They have their own issues, but they don't really belong in pain management. What we're looking for potentially for use would be the musculoskeletal muscle relaxants. And so these are the agents commonly thought of, like cyclobenzaprine, carisoprodol, and metaxalone. And each of those that are listed there, amongst the others that are available within the class, have their own problems. Cyclobenzaprine is similar to TCAs and is limited by anticholinergic side effects. But if you are going to use it, stick with the lower dose, because the lower dose is just as effective as the higher dose, and it potentially might have fewer side effects. Carisoprodol that I told you you should avoid, and I mean it. It's because carisoprodol is metabolized to meprobamate, which is a barbiturate derivative. So that can be problematic, but it also has a higher potential for abuse comparative to the other skeletal muscle relaxants. And metaxalone may cause less drowsiness than cyclobenzaprine, but it does require 4 times a day dosing and is much, much more expensive. For non-NSAID topical analgesics, we have things like lidocaine, 5% patch, which is approved for postherpetic neuralgia. Over the counter, there's a 4% patch. It has the same effect, same clinical benefit. And what you're often seeing now is many formularies are actually pushing patients and prescribers towards that 4% over-the-counter product. There's items like Bengay, Flexol 454, and other topical analgesics. And the question is, what provides the most benefit, the product or the actual application of the product, because of the physical manipulation and massage that it's required to put these on. Capsaicin, for good, bad, or indifferent, definitely has its followers, but it's important to recognize that the labeling differences can be extreme. It can be in concentrations as low as 0.025%, but all the way up to 8%. It can be effective for the syndromes listed there. And it works on this vanilloid temperature receptor and can find its best role and best data in chronic distal painful neuropathy. We'd be remiss if we didn't conclude the drug portion of the discussion with just a brief overview of herbal medications for pain. So the first two that are listed here, feverfew and butterbur, have both demonstrated some minimal effect in migraine, either treatment or prophylaxis. And then alpha-lipoic acid has continually been studied specifically in diabetic peripheral neuropathy, with perhaps some positive outcomes at the dose listed.
This is a very good visual just to wrap your brain around how chronic and acute pain are different. With acute pain, we really do focus first on regional techniques, and by the time someone is dealing with chronic pain, the majority of the treatment really should be NSAIDs, adjuvants, and then the non-pharmaco techniques. So what do we have for non-medication pain management? When you think back to the first discussion we had or webinar with all of you, we talked about how the United States consumes 80% of the world's opioids. So there's something to be said for our culture and our approach to pain, whether it's because we live in a fast-paced world and we want to see immediate results, or we're all working long hours and can't do things such as psychosocial counseling or physical therapy. There is definitely a different approach in the United States to pain. The non-pharmacologic techniques that we have are actually varied and many. It is not an area where there's as much robust literature, although I would say chronic pain itself is a condition that we're struggling to find anything that will be a one-size-fits-all. It's an individualized treatment, and not every patient is going to respond the same way. One of the most important things to do is cognitive behavioral therapy. This helps the patient adjust to the fact that they do have a chronic disease and what it means to live with pain, and also the concomitant depression that can come with it. The physical therapies that exist are heat and cold therapy, which I'll talk about in a minute, exercise therapy. So if you think about fibromyalgia and low-grade exercise, but also exercise releases endorphins that can help with pain management. There are several types of massage that I'll talk about, and then TENS units, which can stimulate the nerve at a peripheral, superficial level and override the sensation of pain to the brain. Spinal manipulation has existed for a long time, and I'm going to talk about some osteopathic techniques. And then there are a host of complementary therapies. Acupuncture probably has the most data behind it, but then there's hypnosis, biofeedback, meditation, music therapy, and yoga. One of the things that we are still struggling with patients is that even though it hurts, rest is not always the answer. So getting up and moving your body, especially the injured areas, can be better than lying in bed, especially for for back pain. So instead, being able to manipulate or mobilize joints or locations where there is pain is the mainstay of treatment. I'm going to jump to the bottom for a second and say cupping became very popular, obviously, after the Olympics, with everybody seeing the marks that was on, what's his name? Michael Phelps, sorry, I almost said Ryan, who was his competitor. There is limited evidence for this, but the idea is that it mobilizes the connective tissues that can become adhered with chronic inflammation and then release some of that discomfort. Traction is not a standalone treatment, and you have to be careful of spinal disease before you use it. Electrical stimulation, otherwise shortened to STIM, can be done by physical therapists, and this is literally by taking small needles that are put into trigger points and myofascial pain points, and then there's a machine that turns on that uses an electricity to stimulate it, have fasciculations that occur in the muscle, and again, alleviate some of the pain. TENS units are similar, but it's transcutaneous with pads that can be placed on the patient's skin. There's a short training that you can give your patient on this. The sensation alone from the TENS unit can override the pain signal from the area of interest, but also if you turn it up for about 20 minutes, 2 to 3 times a day until the point that you get muscular fasciculation, it can actually retrain and break down the cycle of sending the pain message to the brain even after the acute injury has healed. Exercise I mentioned briefly. Myofascial release is similar to cupping, trying to mobilize those tissues that become adhered with chronic inflammation that occurs after an injury. Graston uses stainless steel, I'm trying to think of the right word, tools, a multitude of tools applied to the body in a particular manner. It can be quite painful and cause a significant amount of bruising. And the thought behind this is similar to that of cupping, that you almost reintroduce or re-injure the area for proper healing the second time with increased blood flow. I've listed several different types of massage. I'll let you read about them on your own, but there are different techniques that work, and some may find one or another more helpful. And then at the very top is OMT, which I'm going to talk about next. So the problem with the alternative treatments are the devil really is in the details. When you try to read the studies and see if they were beneficial or not, this 2004 review really is a classic example. So this was a review that looked at when OMT was helpful or not. And patients who are otherwise healthy with an acute or chronic injury, say a sports injury that has sort of persisted over time, are the ones who do best and derive the most benefit versus your chronically ill patient. There were lots of reasons that this review touched on that might be. But again, OMT is probably most beneficial to your average healthy person who maybe has a long-term running injury or low back pain from positioning at work versus someone who has a significant health burden. There are 4 different techniques that they use. I've listed them for you to peruse at your leisure. They all do work a little bit differently. I think the one most people know whether they've had OMT or not, is the thrust or the cracking maneuver that is also used by chiropractors. Cryotherapy and superficial heat do have good response. The sort of dictum that we've always used is ice the first few days to reduce swelling and then heat thereafter. There were a couple of studies that came out that said for a particular patient, one may feel better than the other. So I am always careful with my patients to say, if ice continues to feel good, it is okay to use that. There have been studies looking at things like ice baths after running to reduce injury. And there was a new article that talked about heat shock proteins that are released from hot environments that may help reduce inflammation and might be the reason that heat is effective. We have a list of things that you should not use in combination. And then other things that you can do in the office with your patient, talking to them about corrective posture. A lot of young teenagers and 20 and 30 something year olds have been looking at their phones actually for such a long time with the advent of social media that they're starting to have cervical neck arthritis. So asking them to lift it up to eye level, positioning of computers at work, making sure that for those of your patients who have chronic pain and are runners, they're not tightening up their shoulders with the activity. Sleeping position, so someone maybe with low back pain, making sure if they're sleeping on their side, they can put a pillow between their legs, or if they're on their back, something under their knees to take the pressure off their back, but certainly not sleeping on their stomach. Weight reduction is always difficult, but also always helpful. Working with your patients on weight reduction and low impact exercise, starting slow and then increasing as they go. Lifting of heavy objects is probably one of the things that I do the most education on for my patients, even my patients who feel that their job is not physical. We lift at home all the time. It's unavoidable, and so that they don't pull the muscles in a manner that's going to increase stress level. And then last but not least, stress reduction. If you look at the biopsychosocial model of pain, reducing stress, treating mental health conditions, and also having support systems in place really do help patients deal with pain and reduce pain level reporting on different intake scores. Here are some stretches that patients can use to strengthen their abs and reduce low back pain. There's the pelvic tilt, which is pretty easy to explain to them. There are plenty of websites you can print out either for videos for them to go and actually watch or for instructional forms. So the knee raise actually helps both stretch the paraspinous muscles, but also the hamstrings so that they're not pulling on the back all day long, which is a frequent cause of low back pain. And then the partial press up, which helps both strengthen the low back, but also stretch in a form that's similar to yoga.
So as we approach the end of the last couple of slides, we thought it would be helpful to have this summative table. So if there's nothing that you take away from this talk today, then let it be this chart that demonstrates where the data is in the efficacy for outcomes and use in acute versus subacute or chronic pain. So we thought that would be helpful because it walks you through the pharmacologic benefits and the non-pharmacologic benefits in acute and chronic pain. But lastly, the impetus for this discussion was really because of the situation that inheriting or absorbing a patient that's on chronic opioid therapy and how that affects a number of other items. So we know that the longer a patient is on chronic opioids, that their tolerance and their physical dependence certainly increases over time. And compared with opioid naive patients, they have greater severity of postoperative pain, as much as 3 times higher in the literature. Their use of opioids postoperatively is 3 times more, and they require epidurals for as much as 3 extra days postoperatively. So this idea of untreated or undertreated acute pain certainly plays into the development of chronic pain. And yet we know that if we can manage their pain effectively in the acute situation, that they can have better outcomes over the long term. And hopefully today you were able to pick up some key tidbits and clinical pearls on best methods by which to do that and minimize overall opioid use. So with that, we can take any questions.